Good morning, good afternoon, and good evening, everyone. Welcome to the USAID Global Health Local Capacity Development webinar series, which is facilitated by the MPI Expand project. My name is Elizabeth Neeson, and I am the Field Support Director for the MPI Expand project. I am actually not the scheduled moderator for today. Our scheduled moderator will be calling in from USAID in Madagascar, and we're having some connectivity issues this morning. But once she's able to join, I will hand the reins over to her to moderate the rest of the program. This morning's webinar, Strengthening Civil Society's Role in Resilient Health Systems, is the fourth webinar in our series. We will dive into how civil society supports more resilient health systems through the strengthening of their health workforce and community health workers. The first part of our webinar features 4 speakers who will share their experiences supporting local health systems and delivering community-led health initiatives through community health workers. The second part of the webinar will be a question and answer section, where we will take questions from our audience and facilitate a discussion. If you have questions during the presentations, please put them in the chat box and we will try to get to as many of them as we can during the Q&A session. Please note that the webinar is being recorded, and at the end, we will share the recording and slides with all of you via email. They will also be accessible on the MPI Expand website, and we will share that website address. Also, we will be tracking attendees and CLPs for USAID staff, and they will be offered pending further guidance on the CLP program. With that, I'm giving the floor to Carla Fossen, Director of the Office of Country Support with USAID, to provide our opening remarks. Over to you, Carla.
Thank you so much, Elizabeth, and hello, everyone. Welcome to those of you joining from Washington, D.C. and around the world. On behalf of the Global Health Bureau and specifically the Office of Country Support, I am pleased to welcome you all to this really important discussion. As Elizabeth mentioned, this is the 4th webinar in the Local Capacity Development and Global Health webinar series that USAID is hosting. And today's discussion will focus on strengthening civil society's role in resilient health systems. This series is possible thanks to the collaboration between USAID and 2 of our flagship projects, the Local Health System Strengthening Project and the New Partnerships Initiative, Expanding Health Partnerships, which we like to call MPI Expand. This webinar is actually part of a year-long webinar series that will convene discussions with health practitioners from USAID and around the world on best practices, challenges, and current trends in local capacity development and global health. USAID's goal for the local capacity development is to promote sustainability and better health outcomes for the people in the countries where we work. We hope that as a result of our work, organizations across the public, private, and civil society sectors strengthen their capacity to identify and lead solutions for their health sectors. USAID has developed a resource hub, workwithusaid.org, that empowers new, current, and future partners to navigate how to work with us. By visiting the website, you will gain access to a variety of innovative services and curated resources, all designed to improve your organizational readiness. USAID has also developed a new agency policy that lays out a shared vision for local capacity development. The policy was disseminated for external comment last month, and we hope everyone here who has a stake in local capacity efforts has had an opportunity to provide feedback. We are working on integrating this feedback into the final policy. Now, I have the pleasure of introducing Kelly Saldana, who leads our Office of Health Systems, which is leading the agency's efforts to implement our new vision for health system strengthening. This vision prioritizes supporting local, country-based institutions and organizations so they can lead their own solutions to increase the resilience of their health systems. Now, over to you, Kelly.
Thank you, Carla, and thank you, Elizabeth. I'm really excited for the opportunity to talk about this topic. As Carla mentioned, it's one of the main priorities in our new vision for health system strengthening. Our vision talks about how to strengthen resilient health systems and recognizes that that cannot be achieved without the active participation of local partners, from civic organizations to private institutions. Solutions and innovations for enhancing health systems are not possible without the people and the organizations based in the communities where USAID works. And we recognize that really, in order to strengthen health systems, we need solutions that are tailored to the local context. And to identify what those solutions are that are tailored to the local context, you need the wisdom and expertise of the local populations and the local communities. Locally designed approaches that account for the unique conditions within each country and their culture and health system will result in higher quality healthcare that can reach the most vulnerable populations in society. When local organizations identify solutions, the ownership, accountability, and self-reliance throughout the system is strengthened. And really, this is the critical piece to make systems resilient, because the more that people own them and are able to, and know them and are able to adapt, the more resilient those systems are. We think about local actors through a broad spectrum of local stakeholders, which includes public health officials, community health leaders, private sector providers, and frontline workers, all who have a role to play in identifying and addressing the problems they see within their healthcare systems. And we work to support efforts that enable this full spectrum of stakeholders. In Liberia, we supported and are currently supporting the government with a new national community health policy that formally recognizes the role of civil society, including communities, to plan, manage, and monitor the quality of primary health care at the community level. In Mali, we've focused on building the capacity of civil society organizations to take part in a national community health integration strategy. The aim of the strategy is to formalize community health workers into the national health strategy by creating a national community health worker training program and to get them officially recognized as civil servants. And we do this by collaborating with the government to include them in their national human resources database, which also helps to identify ways to for the system to be resilient, as we know which workers are where and how they can move around. We've also in Mali supported national advocacy coalition so that interests from the community level are adequately represented in national level government efforts. And I'm really excited today to hear further examples of how civil society and community frontline health workers are uniquely suited to identify solutions for strengthening primary health care for communities and to build more resilient systems for their countries. We will also hear from leaders in the private sector and professional associations, additional key actors from the local level in building resilient systems, who will share their experiences of partnering with civil society. These healthcare leaders play a crucial role in building platforms for advocacy, for including civil society, and for community health workers in the policymaking for overall health systems. I hope you, as our audience, will continue to attend these local capacity development webinars that Carla mentioned are part of a series, and that we continue to plan over the next year, because we really think they're critical and important discussions where we can learn from you all and from local stakeholders. So now I'm going to turn it back over to the moderators for today's discussion. I don't know if Jemima has been able to join or if that's Elizabeth.
Jemima has not been able to join us. We're still working on the IT issues here, but we're hoping that she will join eventually. And thank you so much, Carla and Kelly, for those important remarks. So next, I am pleased to introduce our 5 panelists who will share their unique experiences supporting local health systems and delivering community-led health initiatives through community health workers. So first, I'd like to welcome Julius Mbeya, co-CEO of Lwala Community Alliance in Kenya, and Uniter Odoyo, a community health worker in Kenya who is supported by Lwala. So over to you, Julius and Uniter.
Thank you very much, and good afternoon, everyone, from wherever you are tuning from. We are tuning in from Kenya, and it's a great opportunity for us to be part of this conversation. I think a conversation that is really timely, considering recent conversations on the role of local actors, and particularly local organizations in building resilient health systems. And I think in line with USAID's own goal around journey to self-reliance, there is no other way of ensuring that the health systems that are being supported remain resilient other than to look at solutions that come from within. We'll talk about Lwala, and as I've mentioned, we work in Kenya, in southwestern Kenya, and also nationally with the Ministry of Health. And I just wanted to place a little bit of context right now, because when we're talking about health and the dire situation of the health system in the global south, we might be reminded once again at the scale of the problem that we're trying to solve. And from what I know from statistics is that about 400 million people do not have access to basic health care, and that others estimate that about 1 billion people worldwide will go without accessing or seeing a healthcare worker. When you look at the human resources for health front, we know that we have an acute healthcare worker shortage, estimated to be about 18 million in the next couple of years. Lwala works around these issues, and where we're working, we're facing similar challenges that the global health community face, with our focus being on maternal and child health. And as been mentioned, we are a Kenyan founded and Kenyan led organization, founded about 15 years ago, trying to address or move the needle on these key issues that affect mainly high maternal mortality and under 5 deaths. We were founded by a community that believed that it was unfair and just not to receive good quality care. And from very humble beginnings of addressing that need from creation of a health facility, we moved on into a public health program that addresses systems level issues that affect mothers and children in Migori County and in Kenya in general. What we implement right now is a model that we are calling community-led health model. And this model has been iterated on over the years, borrowing from my experiences and expertise in delivery of community health. And this model has 4 pillars. Number 1 being community committees. I believe that community structures are well positioned to create accountability and hold the health system accountable. And going by our own founding, where communities stood and came together to create a solution, we believe that we should place power in the hands of communities to continue to play that role. The second, and so we do that through strengthening of community health committees in the Kenya health system and the health facility management committees to be able to play that accountability role. The second component to the model is working with community health workers. Now, a majority of us are conversant that these are lay healthcare workers. In Kenya, they are mainly referred to as community health volunteers, but we prefer community health workers because they are doing legitimate health work and are driving outcomes at the household and community level. The uniqueness of our model is that we incorporate former traditional birth attendants and midwives to ensure that these cadre of people that have been ostracized from the health system can make a contribution, and that we can tap onto the legitimacy that they have with communities. We also work at the health facility level, where we strengthen health systems and ensure that as community health workers drive demand from the community level, that health centers are prepared to deliver and provide the much needed quality care. And lastly, the model talks about data and measurement and ensuring that we can rigorously measure impact and get that impact with global health community. Some of the results that we've seen as a result of this model is that we have seen significant reduction in under 5 mortality. in the areas that we serve directly right now, population of 125,000 people, we have evidence from scientifically proven researches that we have been able to reduce under 5 mortality by nearly 64%. Communities that we serve, nearly 98% of the women deliver at a clinic, and children are immunized. And also we have done studies that show that we have better performing community health workers as a result of ongoing support that we provide from them. Now, for this to impact the health system, it means that we have to go beyond direct service delivery to impacting the health system and making the health system resilient. And so our health system strengthening approach places us at this unique intersection of policy and practice, where on the one hand, we are providing direct service and delivery to key populations or key people in the community, while at the same time engaging at the policy level. And what we've done with the Ministry of Health in Kenya is to direct our support mainly through the Division of Community Health, where we are trying and supporting development of policies like the Community Health Services Bill, the Community Health Strategy that has just been released 2020-2030, 2025 I mean, the Electronic Community Health Information System and Digitization Strategy. And once we have provided those policy directions and support, then we provide a platform upon which this can be tested. So that cyclic interaction where you're having direct implementation, policy implementation, and continuously improving the health system. Now, this solution is going to scale, and so we have determined that we want to continue engaging. Probably the person who is, you can go 2 slides forward, and yeah, is that the current support is going to service expansion, where we are serving about 150,000 people, and we are working with one of the 47 county governments in Kenya, the Migori County, that has about 1 million people, to be able to scale this impact and create a model county from where other counties can learn from. And we also believe that we can be able to continuously advise and make our impact felt at the national level through policy influence and advice. But to bring this closer home, I think I just want to give a few minutes to UNITA to share with us who she is and the work that she's driving in as part of this local solution that is driving change at the local level. Over to you, UNITA. Thank you.
Thank you, Mr. Julius. I'm UNITA Doyle, a community health worker from Kenya, supported by Lwala Community Alliance. Being a community health worker, I'm also a team lead to my fellow community health workers, where I usually do for them mentorship while we are there in the fields. As community health workers, we offer health programs whereby we check on WASH programs and vulnerables. Sexual reproductive health, maternal and child health, and early maternal childhood development. The health programs, the households for checking and giving health education in those various households. We do referrals for the sick and do follow-ups at the same time. Yeah, so as CW, I'm also a CW advocate. We are also advocating for CW's Advocates Coalition, whereby we want to advocate for CHWs like me to be paid by the governments, the policy to be there such that they have to be recognized at the same time. We also need the government at least to give us equipment and supplies and offer trainings to the CHWs. Yes, thank you. Back to you, Julius.
Yeah, thanks. And Elizabeth, over to you. I know we'll have opportunity to continue conversing in the course of the webinar. Thank you.
Wonderful. Thank you so much, Unitor and Julius. And it's nice to hear the voice of a community health worker on this panel as well. Okay, wonderful. Our next panelist is Mercy Chikozi, Executive Director of Wandikweza in Malawi. Over to you, Mercy.
Thank you so much, Elizabeth. And good morning, good afternoon, good evening to everyone, depending on the area of the world where you're hearing us from. My name is Mercy Chikozi. I'm the Executive Director and founder of Wandikweza, an organization that we're working in Malawi. Next slide, please. I'm here to present on what Wandikweza is doing in Malawi. So Malawi has a population of over 18 million people. And the main challenge, as the other panelists has said, it's lack of people to have access to essential health services. And in Malawi, like 50% of the population cannot access the health services. And this leads to delayed access that leads also to preventable deaths. The main challenge is timely care. Next slide, please. Wandikweza, it's a community health systems organization, strengthening systems organization, providing access to quality health care to ultra-poor Malawians in rural, remote areas through preventive, proactive care towards attainment of universal health coverage. And we are working in Dowa District, Malawi. Next slide, please. We aim to solve delayed access to quality health care, and the delays may be due to knowledge deficit, cost, distance, or inadequate human resources, as well as non-availability of health facilities. So Wandikweza partners with the Ministry of Health to build, deliver, and strengthen community-based health services that provide primary care to everyone who needs it and when they need it. Next slide, please. Our target population is the ultra-poor, living in rural, hard-to-reach areas in Malawi. These are women, children, youths, and men. Next slide, please. So Wandikweza, we build by partnering with the government to build well-trained community health force. These are community health workers. And we deliver essential health package through integrated services provided by community health workers. And we also strengthen the community engagement in ownership of community health. Next slide, please. So we have 4 programs. The first one is we have 130 community health workers. These 130 community health workers proactive research for patients through door-to-door home visits. They treat minor ailments at home, and they also make referrals. And they can treat like malaria, test for pregnancy at household level, and make referrals for early management. Next slide, please. Our second program is Nurses on Bikes. The Nurses on Bikes provide maternal and child health, and they also provide community rapid response at the doorstep. So for example, if a community health worker meets something that they cannot handle, maybe a child is convulsing, they make a call to a nurse on a bike that provides the care at the doorstep and make referrals where necessary, or they can complete the treatment at home by the nurse on a bike. Next slide, please. We also conduct mobile clinics. We conduct 8 mobile clinics a month to decongest public health facilities. We have a team of doctors, clinicians, and nurses that travel as far as 25 kilometers to hard-to-reach areas and provide these needed services. Next slide, please. We serve over 3,000 patients a month through the mobile clinics. And as I said, we travel as far as 25 kilometers to areas where people could not have accessed the health services. Next slide, please. We also have a health center that has a target population of 30,000. We provide general health care services as well as maternity health services. Next slide, please. So our health center is in the community, and we also provide services like ultrasound scan, and that's one of our women that was being discharged, going home from our maternity wing. Next slide, please. We are also responding to COVID, and we have facilitated 9,645 people to get COVID vaccinations. And we do this through village to the village vaccination. So we have community health workers and nurses taking vaccinations to where people are. Next slide, please. Our results, so far we have seen patients, or we have served patients, over 370 patients. We have conducted mobile clinics to hard-to-reach areas over 200, that's 297. And our community health workers have provided home visits for active case finding, diagnosis, treatment, referrals, or follow-up over 400,000. And 90% of our children access services from community health workers within 24 hours of making a call. So when there's a patient, a mother or a guardian can make a call to the community health worker, and then they are there. Our vision is to end preventable child and maternal deaths by 2030 and reach 5 million people with quality services in Malawi in 5 districts still by 2030. Next slide, please. This is what we can do together. We can provide access to maternal and child health in rural areas. We can train and hire community health workers. We can ensure 90% of sick children have appropriate treatment for common childhood illnesses, provide home-based care, guarantee that 90% of community health workers have supplies that are needed for treatment, as well as work with the Malawi government in partnership to reduce maternal and child health mortality. Next slide, please. And thank you so much for listening. And you can connect to us through LinkedIn, Facebook, or WhatsApp, or check our website. Over to you, Elizabeth. Thank you so much.
Thank you so much, Mercy. Wonderful job. It was really nice to see the results that you've been having. And I really like the nurses on bikes delivery of these services as well. And it's nice to see you getting out to those poorest of the poor areas and those harder to reach areas. Okay, now we will hear from Salma Jouni, CEO of Health Care Accreditation Council in Jordan. Over to you, Salma.
Thank you. Good morning, good afternoon, good evening to all our audience. I am very happy and honored to be sharing with you the work of the organization I serve in, the Healthcare Accreditation Council of Jordan. And to tell you a little bit how we have grown from a USAID funded project into a health system strengthening organization for Jordan and the region. Just before I start, very quickly, Jordan is part of the Eastern Mediterranean region, unlike where my other colleague panelists come from. And it is a small country and not rich country. However, it has a very big healthcare system. Next, please. It has been really, next slide, please. Yeah, thank you. It has really been doing very well in terms of the overall health indicators, serving the Jordanian population and the neighboring population as well, because we have a lot of instability around us and we receive a lot of refugees, and our population grew very quickly in the past 10 years through a system that is provided through the public, private, military, and we have quite an extended primary healthcare centers and hospitals all over the country. Next, please. However, our challenges have always been a weak quality system. When you dig deeper into the organizations at the micro level, looking at infection control, policies and procedures, continuity of care, waste management, you find us not doing that well. And as well as at the macro level, the regulations are not very well enforced. Policies and clinical guidelines, reporting culture are also poor, as well as continuous education was not very high on top of the requirements of the government. Next, please. So basically, the government of Jordan came to USAID in early 2003 and asked them to support in improving at the institutional level the quality of care. And the recommendation was to develop an accreditation system that is based on international standards that are localized, and to support those healthcare institutions in improving the quality of care, the environment, and all what that comes with it. The project was quite unique because unlike other projects where we come in with an intervention, the project was designed to develop the local technical expertise in the area of accreditation, safe care, quality, patient safety, ensure that it's working at the international benchmark at all times and receiving international recognition, and designing it in a way to leave behind after the project funds and a local institution, a national body that would continue to provide the services that were envisioned. And that was quite unique for a project funded with donor funding. Next, please. So today, the Healthcare Accreditation Council is actually a private-public partnership, not for profit, managed as a private sector company, however, focusing on the national support for all types of quality improvement activities, whether it is safe healthcare or training providers or making sure there is a supportive environment. We provide services through accreditation, consultation, capacity building, and research. And I take this opportunity to say, to focus on capacity building, which is the core of our discussion today as well, because we realized at the onset that being only an accrediting body is not enough. If the people that are required to adhere to the standards are not trained, do not have the skills, cannot move forward with what we're asking with them, it's going to be very hard to change. So we had quite a focus there. And I think with us being in this position, USAID has left a legacy in Jordan that continues to work for the improvement of the health systems in Jordan. Next, please. This sustainability and self-reliance is in part due to the project that initiated HCAC. It also, and the design of it, and it also is important because of the flexibility and diversity of work. We get our funds from corporate sponsorships. We are now a prime contractor for USAID on certain activities. We also get grants as subcontractors. We require fees for the services we provide in education or accreditation or consultation, and we run campaigns for advocacy and research purposes and national level. We're very proud that we have quite a strong trained workforce in quality improvement, infection control, risk management, you name it. More than 250 accredited organizations across the country, from labs to primary healthcare centers to hospitals. We have a number of tools and programs that we provide. We've influenced government policy changes, and we still do that. And we have a growing awareness of what it means for patient safety and so on. And I'll take just a very quick opportunity here to mention, and we'll discuss it later maybe, that even during COVID, we had a very big role in terms of showing that accredited organizations and the trained workforce were more ready to deal with the COVID requirements than any other organization. I will end with 2 slides because sometimes pictures speak more than words. When we enter into organizations, we see the likes of those pictures, and no patient or family member ever thinks about what's going on behind the scenes. Where is my medical record? Am I getting expired medication or not? Is there proper infection control? And after we work with an organization, we leave it with a much better, stronger system that is based on policies, procedures, implementation, data collection, as well as trained workforce and safer environment. Thank you very much for listening. I look forward to your questions later in this discussion.
Thank you so much, Salma. And you're right, a picture is worth 1,000 words, and love to see the before and after. And then really nice to hear that you saw some, immediate application of all the efforts in the, more improved response to COVID. So thank you. Okay, our final panelist is Dr. Jeffrey Barrow, Director of Health Connect Jamaica. Over to you, Dr. Barrow.
All right. Hi, everyone. Thanks again for inviting me to speak about our very exciting project. We're happy to discuss what we have already achieved and look forward to any comments and feedback that you may have. Next slide, please. So I'll just give you some context as to why we started this project. Could you just press forward? So here's just a quote from the WHO Progress Report in 2019 when we designed the project. At that time, there were global targets for 2020 to end the AIDS epidemic by 2030. And so that report basically said that we need to do things faster, we need to be more innovative, and we need to bring those innovations to scale. Next slide. So when we looked at the national HIV treatment cascade, so this data only represents patients who were being seen in the public sector at the end of 2019. So on the graph, this is what's called the HIV continuum of care. It's one of the frameworks that are used to analyze national data for HIV and programmatic responses. So we see here the red line represents those global targets. And it runs from the estimated number of people on the left or all the way to the ultimate clinical goal, which is viral suppression. And so all the way on the left as well, you see that the main 2 gaps, which are those gray bars at the top of the blue bars, are the retained in care and the virally suppressed. So we coined retained in care on ARVs, which is the treatment for HIV, as the quantity of care being delivered, and then the virally suppressed as the quality. So essentially, we needed to double the quantity of care and almost triple the quality of that care in a very quick and short space of time. So the context is also that the public health sector was already sort of at capacity. And so we needed to find a new method of being able to deliver these HIV treatment services to essentially a low-income population. And so we needed to be able to leverage the private sector in a way that was affordable and accessible to these low-income HIV clients. Next slide, please. And so that's why we developed Health Connect Jamaica. So essentially, our ultimate goal is to provide equitable access to HIV care in the private health sector in Jamaica. We used a public-private partnership model, so it's not officially a public-private partnership yet, but we use that model to integrate both the private sector, the public sector, and then also quite uniquely academia. So the project is actually coming out of the University of the West Indies, where I'm stationed. And so we've been able to link these 3 major groups in quite a unique fashion. Next slide. So in order to rapidly expand, which is what is required, we needed to use a service delivery model that was not your traditional standalone clinic with a group of health service providers at each of those sites. And so what we did is we created this hub and spoke model where we contracted existing private sector providers across the country of Jamaica. So our providers and partners are clinicians, we have psychologists, and then the laboratories and the pharmacies. And then what we did is we centralized a lot of those activities into our hub. So all of the administration, the monitoring and evaluation and the financing is organized in that hub. And we also do service delivery in terms of case management and contact investigation also from that centralized hub. Next slide. So here's a map of Jamaica. And for those of you who don't know, it's English-speaking Caribbean, a little bit south of Miami. And this shows all of the locations. So the white crosses are the clinicians, and then the blue and the red pins are the lab locations. And this is what we have been able to achieve across the country so far. Next slide. So here's a cumulative client enrollment graph, which shows some key milestones. So in September 2019, we got for approval. In April, we were able to achieve the University of the West Indies Medical Research Ethics Committee approval. We launched to the public in July of 2020. And then by May of 2021, we became a direct USAID implementing partner, whereas in the initial phases, we were a subrecipient under FHI 360. So at the end of December 2021, we'd achieved 402 patients in our network. Next slide. So very important for us is we always take into consideration our client perspective on the services that we've delivered. So every time a patient is seen, they're given an automated text message to link to our client satisfaction survey. So here's one of the major features of that, which shows that 96% of people who have access care through Health Connect Jamaica are satisfied and would return for their future sexual or HIV service needs. Next slide. Interestingly, when persons are thinking of why individuals would not like to go to the public space and would prefer to come to the private sector, a lot of it is often termed around logistics and operating hours, the wait times, the availability of the services. However, based on the client feedback, we can see that actually privacy, confidentiality, and staff friendliness, or the perception of privacy and confidentiality at least, and the staff friendliness and professionalism that we provide are the major reasons why our clients would return to HCJ for their service delivery. Next. So this is a slide just to show the range of the type of clients that we serve. So it's not just the heterosexual population, but it's also the gay or men who have sex with men. Interestingly, we have people who self-reported as persons who paid for sex, so clients of sex workers. Injection drug use is not a common feature of the population in Jamaica at all. And then we can also see that persons of trans experience are also accessing services through Health Connect Jamaica. Next slide. So in terms of health workforce capacity building, what we do is we leverage existing training programs that are already existing. We facilitate access for all of our partners and our internal staff. So I'll just speak a little bit about some of those methods that we use, which is the focus of today's presentation. So for our internal staff, we have a partner who provides practical training for key populations. So they will interact, our case managers and contact investigators were trained to be able to provide the tailored needs for men who have sex with men, commercial sex workers, and persons of trans experience. And it's a really great program because we actually are able to interact with individuals from those communities through those training sessions so that they can provide feedback of how the population would like to be treated. Next is national cadre specific, sorry, go ahead. Yeah, so the Ministry of Health provides these cadre specific training updates. So all of our case managers and contact investigators are integrated into those national training programs, as with the majority of our service delivery. And then finally, we provide case-based training. And what I mean by that is we do what we call quality of care interventions with all of our partners. So we have these multidisciplinary teams that come together. So our internal staff and our partners, the psychologists, the clinicians, the pharmacies, and the labs sometimes participate in these monthly, bi-monthly interventions at the individual level. So we discuss difficult clients. We go through how we are going to coordinate those services, and we also learn from each other in a collaborative method. Next. So in terms of our partners, so these are the clinicians, the labs, and the pharmacies. There are a lot of online training modules that are also provided, and those are both local. So we developed a curriculum for HIV updates especially for the clinicians, and we also have modules for the pharmacies. And then we also access international courses on HIV, and we facilitate the access for those courses to all of our partners, and those are conducted annually. They're also, as I mentioned, also trained for these key populations. We want to make sure that all of our providers, not just our internal staff, are able to respond to those individual requirements for these key populations. And again, the case-based training, as I mentioned, is a multidisciplinary collaborative effort through our quality of care interventions. And then finally, for the pharmacies and the clinicians, there's a national accreditation process. However, it's not disease specific. And so we support those processes with our online trainings, as I mentioned earlier. And that's it for me. Thanks.
Thank you so much, Jeffrey. And yeah, very nice to see the direct interaction and training with key populations as well as your partners. So I'm sure we're going to have a lot of questions for you as well as all of our other panelists. All right, thank you. So I am delighted to share that Jemima Andriamina from USAID in Madagascar was able to join us. The IT issues, I believe, are solved. Jemima, can you turn on your camera and unmute yourself? And I'm going to hand it over to you for the question and answer session. So Jemima?
Yes, thank you very much, Elizabeth. Can you hear and see me?
Yes, we can. Welcome.
Well, that's wonderful. Thank you very much. Sorry that the technology is not always 100% perfect, but glad to be part of this with you today. So I am Jemima. I am a program management assistant for USAID Madagascar and a former fellow with the LCD team. And we are going to take on the Q&A session that will lead us to a deeper discussion, and we will take the questions from the audience in the chat, if there are any here. We may start with a question for Mercy. Mercy, how do you go about selecting social entrepreneurs for support?
Yeah, thank you so
I think
much,
you're speaking
Jemima.
on mute.
Can you hear me?
Yes.
Okay. Yeah, so we select the social entrepreneurs. First of all, we work with the community health workers. So these are our primary social entrepreneurs in our program. And we also work with child-headed households. These are orphans and vulnerable children from child-headed households that we empower them with social entrepreneurship skills so that they have a source of income at the household level. Thank you.
Thank you. That was very insightful. We have got other questions for Salma and Mercy still, and Julius also. In thinking about how your healthcare facilities were more equipped to respond to COVID, what is the unique role you see for private sector associations or civil society in nimbly responding to emergent public health threats or adapting to emerging public health threats? Over.
I'll take a stab at this question. I think as a private sector company, though we are not for profit, as I mentioned, we had a better, or we have a better ability to adapt and respond in a faster way than government organizations or smaller NGOs because of budget issues, hierarchy, authority, and autonomy. And this was very clear during the COVID situation in Jordan in the past 2 years, where HCAC was able to move quickly on supporting hospitals in their infection control and emergency response plans, to support USAID and WHO in the readiness packages for COVID, their design, their implementation, their assessment, identifying the gaps, and in providing training activities specific to COVID-related issues, though on different topics, not only in terms of management of a facility while receiving COVID patients, but also in terms of breastfeeding for mothers during COVID-19, what to do for general practitioners, for infection control people, and so on and so forth. And for example, we were able to very quickly expand our platform, our virtual platform, which helped us reach a larger number of people in terms of training and dissemination of information.
Yeah, thanks so much.
Thank you very much.
Yeah,
go ahead, Julius.
A little bit. When I look at this, I don't think whether it's a question of either or. It's a question of how do these different players work together to respond. And I think that each of the players have strengths of their own. There are strengths of the private sector, like Salma has ably articulated. There is a place of INGOs and big multinationals that have a place to play. There is a place for local organizations to play. But if I reflect really on the situation with COVID-19 from early 2020, what COVID has taught us, and again, as the subject of this webinar, is the need to invest in local capacities and local organizations. And the main reason for that really being that we saw firsthand that organizations took off, international partners took off when COVID struck. It was the local organizations that were left to deal with the situation and to find solutions. So if we do not build the capacity of local organizations, then it means that probably the gap could have been felt even much more greatly. But to my earlier point of collaboration and what each of the partners bring on board, one of those was made evident by, for example, the effort that was around COVID Action Fund for Africa, which was this big effort to provide PPE for community health workers across 24 countries in Africa. And that effort could have not been possible without the combined effort of the private sector, INGOs, local organizations, and government. It demonstrated very clearly that when these entities are able to come together and to solve a problem, then it's possible to solve that problem. And even right now, as we're thinking about vaccine and vaccine rollout, each of these entities have a role to play. And I think what we should be looking at in thinking about resilient health systems is to ways and means of coming up with strategies for these entities to work in concert with each other rather than in parallel with each other to be able to deal with current and even future crises. Thank you.
Thank you very much, Julius, for that good insight. On that same question linked to that, how do we engage government in playing a role to ensure quality care by the community health workers? Can you hear me?
I will pass this to Unita. I think she's better placed to do this. But I think just briefly on our experience is that we know that community health workers flag such a huge gap in the healthcare worker shortages that we have in our part of the world. I earlier mentioned that shortage is estimated at about 18 million healthcare workers in the next couple of years. And so what are the innovative ways of meeting that human resources gap? It is to empower and strengthen cadres like community health workers, give them the tools that they need to work. And that is why Lwala trains, supervises, pays, digitally empowers community health workers to be able to deliver the work. And you saw in the case of Wandikweza the same, like how do you empower and give the tools that community health workers need. So what we do is to work with the Ministry of Health, one from a policy level of ensuring that we create an enabling environment and framework for community health workers to work. That includes putting in place appropriate legislation like the Community Health Services Bill, both at the national and at the county level. It is to work on supply chain issues, ensuring that community health workers have commodities that they need to work with. It is to work on digitization and leveraging technology to enable community health workers to be able to do the work. And that is why our involvement with the electronic community health information system and strategy for the country, and also hands-on deployment of digital tools that we do with community health workers are important. And then most importantly, is to recognize that community health workers do work and they're supporting the health system and need to be supported so that the health system can stand on its own. Unita, you want to add some insights into that? Yeah.
Thank you, Mr. Julius. Just to add on top of what you just said, us as community health workers, you said we need payments and even the recognition as other healthcare providers, because we find that the community health workers are termed as volunteers, meaning they are not being paid. And if we check for other partners, they do involve CHWs or the community health workers in their activities, but most of them or some of them do not pay the CHWs for whatever they have been doing. So we would wish that if it's a policy that the CHWs are to be paid or being compensated for whatever they do, that one would be better. And even on the part of the trainings, we need to be capacity built every now and again. So through the trainings, I think the level can be raised, all the standards of living of the community members can be raised because well equipped with the knowledge that we give to them. Again, when we talk of the digital tools, I think it's very appropriate for CWs to be given because the manual ones, the books that maybe the CW use as their tools or reporting tools, sometimes carrying them becomes a challenge. And even most of the CWs do not have them because they are expensive to give out or to provide to the CW. At the same time, when we use the manuals, then even modifying the modules becomes a challenge. So we may advocate for the digital tools for the CWs, at least to make work easier and very effective and accurate and timely reporting. Thank you. Back to you, Julius.
Thank you all for those questions. And we have got questions for Julius and Mercy again from William Watkins. What cultural barriers have you experienced when working with communities and local governments? Hello?
Yes, I had missed that question because of my connectivity to the internet. Please, may you come again?
So the question is, what cultural barriers have you experienced when working with communities and local governments? Either Julius and Mercy can take us there.
Okay, thank you so much. So the cultural barriers that we have experienced it depends with the district where we are working with, because even in Malawi we have different cultural beliefs. So one of the cultural beliefs is like women making decisions concerning their health. So for example, if a woman is pregnant and they want to go and access care, they have to wait for the husband to give them a go-ahead to access health. So these are some of the cultural barriers that we have been facing at community level. At the same time, we also face cultural barriers concerning women, whereby they don't have a voice. So our community health workers work with communities so that they are empowered, or they know that women can make decisions that concern their health, that women can assess health even if the husband or someone that is male is there or not. So this is the main cultural barrier that we have been facing concerning women making decisions concerning their health. Thank you.
Oh, thank you so much. Another question for Salma. Can you share how you have worked on quality and patient safety during the pandemic with Jordan, with USAID, or with others?
Absolutely, thank you. To pick up from what I was saying is that being a local organization with the strength of thinking and moving in like a private sector, although we are managed by a public-private partnership, we were able to leverage automatically all our connections and our networks, who were very essential in terms of skills building. As Julia said, it's very important to ensure the development of the capacity of the people who are responding to the pandemic and who are providing services. So specifically, I think our largest work was with the local health system strengthening project, USAID funded global project here in Jordan. And we worked on a variety of things, laboratory related activities, for example, training on quality management systems in the laboratory, technicians, inspectors, quality officers. That was very important. As you know, the lab industry had a huge role, both the public and the private. Training private GPs and doing training of trainers for the Ministry of Health, among other courses that we ran with UNICEF and UNFPA. But with the LHSS, we also worked a lot on the students that are about to graduate or entering or have volunteered into the healthcare system during the crisis, building their capacity, as well as building the capacity of a national team as core assessors for the healthcare institutions. And it's very important here to note that in Jordan, the Ministry of Health is actually a service provider. They own and run and manage and operate hospitals and the primary healthcare centers. So they were very much entrenched in the day-to-day services and how to manage that. While along with the USAID support and specifically the local health system strengthening project, we were able to provide a lot of capacity building. And last but not least, we are also positioned in Jordan's largest public sector referral hospital, where we were able to design and develop programs on emergency response and support in that training as well for a campus that serves more than 40% of the Jordanian population. I think that's in a nutshell as possible, as much as possible was our work during that time.
Thank you so much. That's a good insight. Thank you for that much information, Salma. For Jeffrey, there's a question for Jeffrey. Do the private facilities provide HIV care free of charge? What are your incentive packages for the private facilities established for profit?
Right, very good question, and thanks for that. So we we have a tiered process. So we do an initial socioeconomic assessment of all the clients who are onboarded to determine their ability to pay out of pocket. We use the WHO's 10% threshold for catastrophic health expenditure, and we base that off of what it would cost the patient out of pocket to access those services through Health Connect Jamaica. So the model already subsidizes significant or has huge reductions in cost just because of the way that it's designed. So the clinician out-of-pocket cost remains the same, but for example, we process all of our laboratory samples at the National Public Health Lab, and so right off the bat, there's an 80% reduction in cost for the laboratory fee, which is actually the highest cost for private sector care in Jamaica. And so for those who are able or assessed as being able to pay out of pocket and they have the necessary resources based on our assessments, they pay the clinician fee out of pocket, and then they access those markedly reduced laboratory costs through our network. And then they also get much markedly reduced costs for the access to the psychologist. For the clients who cannot pay, we reimburse the clinicians, the labs, the pharmacy, and the psychologist, and so there's no out-of-pocket cost for the clients. And so that's how we're able to subsidize the patients who need to be supported, but also allow those who are able to pay to continue to pay. And that's why we focus on health equity rather than equality, where it's free healthcare for all, which is how it is in the public system in Jamaica now, which is also why the system is not able to handle the burden of disease and the increase in demand just because the cases are free.
Thank you so much, Jeffrey. Jeffrey, can you focus on health workers' role in coordinating private providers and filling private provider capacity gaps and helping to broker partnerships with the Ministry of Health to support the COVID response? That is something foreseeable as well, I guess.
Right. So what I didn't mention in the presentation is that we have a steering committee which is actually chaired by the permanent secretary for health in the health ministry. So for those who don't have the same sort of English system of ministries, the permanent secretary is the chief technocrat who is not politically assigned. And so he runs and manages the steering committee, and it's a multidisciplinary body, and that's how we have determined and engaged the Ministry of Health on a continuous basis to ensure that we're not a separate vertical program, but an integrated component of the national response for HIV. We're now leveraging those platforms and systems that we've created for the HIV to now start to deliver COVID vaccines, which we hope to get on the way very soon. In addition to not just vaccine delivery using our network, we're also now engaging with other private providers who are really involved with the sample collection a lot for the tourist industry and for the travel. And so what we plan to do is to be able to be the resource for sequencing and the COVID variant monitoring. And so because we are linking in with our private provider who does it for the majority of all the hotels, as well as for a lot of the travel that's happening, we'll be able to rapidly respond to any variant changes that are happening in the country. So it's essentially what we're already doing, which is a leveraging of existing networks and now expanding that service delivery with a reimbursement component, which we already do for the distribution of vaccines as well as the monitoring of the variants.
Thank you, Jeffrey. To relate all that, the next question is for everyone. Can you elaborate more on the strategies to ensure sustainability after the support from the donor ends? Like, what are foreseeable plans and how is that planning going ahead? Anyone can start whenever.
Well, since I was speaking, I'll just go ahead. So we have this larger plan to have this integrated public-private partnership with the Ministry of Health to continue to see the clients that we're serving. What we're noticing is actually there's a large network of referrals that is now happening between the public and private sector. So cases that were previously lost to follow-up are coming across. So we're actually serving a lot of the patients who are originating from the public sector, those who are in care but also tested. And so this larger public-private partnership is what the vision is for the long-term sustainability of the project. What we're also looking into now is the monetization of a lot of the tools that we use, so that the clinicians are now able to use those same referral net booking systems, et cetera, all the IT platforms that we've developed, not only for the HIV and HCJ clients or the COVID clients, but for their entire client population. And so it's really a two-tiered system that we're looking at for our long-term sustainability plan. Thanks.
Any other?
If I may, yeah, I may just say we are happy that today at HCAC we have crossed that bridge. But I would like to tell the audience that it wasn't easy. First of all, you have to have time. I mean, we were lucky that we've had time during the project life cycle to focus on how to strengthen our capabilities as an organization, to think of business development, look at other sources of funding, and put in the systems for that to happen. So bring in a salesperson or a business development person, put a plan, put the financials, because the financials look very different than when you are being supported by donor funding than when you have to run an organization on your own. So I wish and I hope that USAID projects and other donor projects have a component in there to support the local organizations that they are working with to strengthen that area and find it. And then we have to, even if we are an NGO, we have to think like the business sector, like the private sector. We have to have a strategy, a goal. We have to say, no, we cannot do this. We have to focus. So that is also very important. I'm not saying it was an easy ride. The funding stopped in 2013, where today, thank God, a strong organization and working not only in Jordan, but at the regional level. But also, it's very important to say that we had a lot of investment in the non-technical people who are running the strategic and the business and the financial components that keep us going.
Yeah.
If I can add in, and I'm talking from a totally different angle to this, because we're talking from non-profit sector and we always bombarded by this question of sustainability. I think for us is to go back to the basics and to understand health as a human right, and then to ask the question, who is obligated to deliver health to the population? Is the government. And so for us as Lwala, we believe that strengthening the public health system is the way to create sustainability, investing within the public health system, and ensuring that the government or the ministries of health can actually deliver on their mandate. Across Africa, including Kenya, we are still very far behind the Abuja declaration or commitment of spending 15% of the GDP on health. The health needs continue to grow, budgets continue to grow, but the health spending has not grown in tandem with those growths, including population growth. So increasing government spending in health is a key strategy for us, and that is why we are invested in policies and legislation that actually push government to pay more. For example, one of the key tenets of the Community Health Services Law that we are pushing both at the national and the county level is to commit government to CHW payment or payment of CHW salaries. That is an initial first step of ensuring that community health workers are counted, are remunerated, and paid for the services that they deliver. The second way to building sustainability for us is actually to look for efficiencies within the resources available. And I think this is one of the things that have been recognized by USAID around local capacity development and also localization. Recognition that we can actually deliver programs cheaper using local organizations whose overheads do not take 50% of the budget, but that we can be able to drive more and more resources to the people that need them the most. And I think also leveraging on things like technology to deliver healthcare so that more and more people can be reached through non-traditional means and in far cheaper ways. Yeah, thanks.
Yes, thank you so much. For us, sustainability means community involvement. So if we involve the community on each and every step, we are sure that there will be sustainability, because we know the people know their problems and they know how to solve them. So if we take them all along, our programs will be sustainable, as well as promoting local governance at community level. So governance, we have committees like local committees that look at what is happening at community level concerning health. So governance, local governance and community involvement, making sure people are able to find their own solutions to their health problems. Thank you.
Thank you, everyone. And building on that, what kind of capacity development would be useful to your organizations to strengthen the ongoing strategic leadership and systems thinking for your sustainability and strategic role in the health system? Building on what you have just mentioned. Over to everybody.
Can I rephrase? I mean, is it asking us, because it was cutting out a little bit, asking us what sort of leadership support do we need, or should we give leadership support?
Yes, what kind of capacity building, capacity development would be useful to strengthen the ongoing strategic leadership?
If I may ask, because if I may say, in Jordan, it's very important for us to move to measurement. Jordan is very weak in terms of measuring its healthcare outcomes and measuring the quality and patient safety indicators and reporting into a system and building on an overall patient experience. I think training leadership and developing those systems for Jordan would be the next step and would be really beneficial to strengthen the health systems and decisions based on data and evidence.
Thank you so much.
Shall I go? So I think Salma actually outlined exactly the things that we need to start doing, which is really looking at the business case and developing that, and ensuring that we're in a very strong position when we do make that final application for the PPP. The other major thing that I think that we need to do is really looking at the ability to engage with our community. We've been having a little bit of a challenge. People are coming to the private sector because they don't want to be engaged with anyone else except for the single doctor, right? They do allow sometimes for the case managers and contact investigators, but that's I think it's around 40% of people who are actually signing on to that component of it. And so we need to look and see how best we can develop the capacity to engage with the community, because as I think as clearly has been shown, that getting the community involved is a critical component for the ongoing sustainability of the model. So the two things is community engagement and participation, as well as building that business case for our future PPP model.
Yeah, for us as Lwala, I think we are at that stage where we see USAID as that next year partner, and we've worked on sub-agreements or subcontracts before. But I think talking on a platform which is NPI, New Partners Initiative, it is how to understand the barriers and to scale the barriers to accessing USAID funding. I think at the lowest level, at the next level, and all that. That I think for us, what does it take? What does a local organization need to move over the hoops that there are so that they can actually get into USAID partnership. And I'm not talking about like sub-grants that come from primes, but really how does an organization position itself into USAID partnership?
Yeah, thank you. For us as Wandikweza, it would be to strengthen our research skills so that we have to strengthen our research skills for evidence, data, and scientific proof of our programs. Yeah, so research capacity building.
Okay, thank you. Maybe last question quickly. So what kind of tools for Unitarian Jerusalem and Mercy, what kind of tools do the community health workers need in order to be better supported by the health system and to better support the health system?
Okay, thank you. If I may just respond, the tools that we need, initially when I was talking, I talked of the digital app that because as a CWs, there are other tools that we use like the MOH 100, MOH 513, 515, the reporting tools. We would wish that they are being put in one Android, whereby all the digital app, whereby when I go to maybe the field or to the household level, I have to carry one thing with me rather than carrying so many books with me, such that maybe through the weather conditions, they may be destroyed. So the digital app may be of good help for us. The equipment and supplies is also necessary, such that with that provision, the health system can be good, especially to us as CWs, because most of the CWs in other areas do not have other things like the apps I'm talking about, the equipment and supplies, and majorly even on the payment part of it, I talked of it earlier, the CWs or other areas do pay CWs, but not all the CWs are being paid. And for this one to be very effective, at least CWs need to be registered, their numbers need to be known, and where they work, so that even if the payment comes, at least there is accountability that this CW is working somewhere and this CW is responsible for this. So we know where the pay go to. And as I talked of the digital tool again, having books is not all that accurate. I even said it earlier that changing or modifying the modules that are there is not all that easy. But if you have this digital app, the modification becomes easier, and even the reporting itself is very accurate, timely, and efficient as compared to the papers and the books that we carry. I think Julius can add some.
Yeah, thanks so much. I think you have captured most of that. I think digitization as a country, for example, we are through this process of developing a national community health information system for the country. I think that is one thing that would be beneficial, not just for CHWs working or supported by Lwala, but as a country. I think I also need to underscore the fact that USAID is the biggest funder of health in countries like Kenya. So I think coordinated support where all efforts, all investments are aligned and focused on similar goals could be helpful, because I think sometimes when there is parallel support to programs and entities, that is part of the confusion, I would say, that has emerged and has weakened the health system. So how can we channel support in a way that it can actually be able to strengthen the health system? And then I think there has also been misconceptions, or shall I call it, about using USAID funding for supporting the work of community health workers, for example. And I know that a number of programs are hesitant about that. I think taking a position and on that, I think that can be great. But most importantly, I think if this is about new partners and new partners initiative, at least investing in a new or local organization so that that can actually be able to support and buttress the health system. Yeah.
Yeah, I would just emphasize on the supply chain. So community health workers need an interrupted supply chain. I think it's embarrassing for a community health worker to be making referrals because they don't have supplies as simple as maybe diarrhea. Like the community health workers are able to handle diarrhea cases, but if they don't have supplies, they'll be making referrals. So if they have an interrupted supply chain, that would be good for the community health worker programs. Yeah, I just wanted to emphasize on that one. Thank you.
Thank you so much. Thank you so much for joining our Strengthening Civil Society's Role in Resilient Health Systems today. And we apologize if we were not able to answer your questions, but we hope you benefited from the discussions. And we thank our speakers and our panelists, and especially our organizers who helped make the webinar possible, especially Ariela Camara, Laura Wenzel, Cindy Hodor from USAID, and Samantha Lemieux, Will Watkins, Michael Nesson from the NPI Expand team. And we hope that if you have any feedback or suggestions for us, you may use the link that will be posted in the final slide. And have a great day. And we hope to see you at our next webinar coming soon. And until then, continue to interact with our locally led development working group team. Thank you, everyone. Bye.